So this afternoon, what we're going to do is we're going to go over how these muscles stabilize us when we get you out of the left AIC pattern into a neutral state. We're going to go into a repositioned state. And I will give you, we are going to have some time to do that in lab. We'll do a 90-90, we'll demonstrate it to you. What does repositioning really mean? But the opportunity right now for the didactic information in your manual is important because you wouldn't know what to do with that hamstring when I ask you to shift one knee down or up to pull in certain rotational characteristics from that myokinematic muscle or orientation if we don't go over this first. So I always wanted to know, okay, if I take and fold this page like this, fold it right in half a minute. On one side of the page, you have all the external rotators listed. Do you see that? You flip it over, and on the other side, you have all the internal rotators. You see that, Pat? Then if you take it, unfold it, and you fold it like this on the black line, on the top, you have femoral rotators by internal and external rotation, and you have a thing called femoral stabilizers, but you have internal and external rotators on the top. But if you flip it on the bottom, you have internal and external rotators as related to hip extension, knee flexion, hip flexion, and knee extension. So let's see how this works. Okay, Sheila, let's say I want to find out what's the main hip flexor that internally rotates an A on an F or an F on an A. I would say I'd first have to go to my internal rotation side. I go down to where it says hip flexors, and you have one. What does that say, Sheila? Go to your hip flexors, internal rotation, and there's one. You're doing it. I can see your eyes. Go down, scan down the page, find hip flexors. Tensor, fascia, lata, your TFL. Does you see how that works? So let's say, okay, now I want to go and I want to find out what are the two internal and external rotators, there's one of each. What are the two rotators that stabilize my femur, Chad? That stabilize my femur? Well, I go to femoral stability, I go to internal rotation side, and that says what? There you go. Internal rotation side, not external.
The bicep more.
See how it made you work? I asked a question. You went to, I had to find the thing that said femoral stabilization. IR would be what? Say it, you had it.
Internal rotation.
Would be bicep femoris shorthead. The bicep femoris shorthead is an internal rotator that stabilizes the long bone shaft called the femur. Along with what other muscle that's going in the opposite direction of the femur, just go right across the page. External rotation along with the
adductor magnus.
The adductor magnus and the bicep femoris shorthead stabilizes your femur when you put weight on it. We'll come back to that. So if I asked, let me do another thing. Jacob, tell me the three muscles that extend the hip that are also external rotators. So you go to the external rotation.
Adductor magnus, bicep femoris, long head, tibial head, and gluteus maximus.
So now with that question, Chad, what did your bicep femoris shorthead do to the femur?
Stabilize.
And it did. And what column was it in?
Internal rotation.
Correct. And what did your long head do?
External rotator.
And what column was it in? Okay, so basically, see how I'm moving around this thing? It's just a great little cheat sheet. It's not really a PRI cheat sheet. It's just something I did for myself, so I could teach when we color these muscles, what are we really thinking about with each muscle? All right, and then I also did, if you look at it closely, you'll see that I'm taking some fiber. Under internal rotators, I said anterior fiber, iliotibial tract, Gertie's tube. I'm kind of pulling in some key elements on each muscle. Now the A&A, the attachment sites, we're going to talk about where that's at in your manual, but right now, that's how that's being used, okay? So that's what's on page 15. What does the asterisk mean, Mike, on page 15? What does that asterisk mean? At the very bottom of the page, what does that mean?
Two joint.
That means that muscle that we're talking about crosses two joints. And right away you can see where that's happening. I see a rectus femoris cross two joints. Do you see that? The rectus femoris muscles on both, on which side? Mike, which side is that on? External rotation side. Are there any internal rotators that cross two joints? What would that be? Who found it? What was it?
Semitendinosus.
Semitendinosus crosses two joints. Kind of like a trick question, but man, you get full points if you get that one, and you knew it. Okay, so we'll come back to those muscles, but that's how it works. On page 16, right across the continental divide, go across the book, you go all the way to the other side. I also gave you all the proximal and distal attachments. Do you see that? They're not listed by O and I. We just call it proximal and distal and proximal, along with the innervation for each muscle. You have external rotation, Chad. You have internal rotation. And there, Mike, are those femoral stabilizers Chad was talking about. So we got three more groups on the other side with proximal and distal attachment sites. Sheila, I don't expect anybody here to memorize all that. But what I do want you all to know is that they're in groups. They were in a group. Let's talk about the groups, everybody. On page 15, the first group is external rotators. That's a group. And internal rotators. That's a group. Then you got external rotators that are hip extensors. That's a group. Now, in myokinematic thinking, that second half of that page is what you really want to learn. In other words, what are the internal rotators as a group for femoral and hip and knee flexion and hip and knee extension? Because that's where the myokinematic principles come alive. Do you follow me? That's when you know, as a group, those two or three muscles or that one muscle by itself, because there's no other muscles that'll do that. By itself, that one group is responsible for knee extension with internal rotation at the same time, or vice versa, external rotation at the same time. And yes, by a group, by the end of the day tomorrow, you should be able to tell me what's significantly the most important thing for each one of those myokinematic groups. What should you be really capitalizing on? Look at the innocent little tensor fasciae lata, the muscle that everybody wants to chop up, dice, mince, and meat up. Do you follow me? Look at that little guy, TFL. Do you think you're given a TFL if you didn't need it? Guys, it's the only muscle that does what? It's the only muscle that flexes your hip and gives you internal rotation when it does. Why would you sit there and cuss that muscle if it doesn't shut off? When the problem is it's doing what it has to do because the position it's put in with its attachment sites. You can get all upset about a psoas or all upset about that little tensor fasciae lata. But if you don't understand what inhibits that muscle by taking it out of the position it's in, it will only do what it's going to do because it's the only muscle in that group myokinematically that has that attachment site for the purpose of generating forces across that joint the way it does. If you need internal rotation, a transverse muscle that is been taken away by the other groups of internal rotators, and there's a few of them up on the top. If those internal rotators are not in the right position, I know a lumbar spine that would love to give you 40 degrees and love to help you find out that internal rotation from one muscle. Did you see what I just did? So you can go back after that muscle, but don't cuss the muscle. Did you preserve neutrality at 30 degrees of the lumbar spine? Because if you didn't, that muscle's going to do exactly what you want it to do. It's the only one you've got when you're in hip flexion. You may say, I love this PRI thinking, and get up and forget what muscle?
Hamstrings.
And you're right back to using your TFL for internal rotation. You guys understand what I'm doing for you right now? So before you start stretching and cussing muscle and going after trying to stretch muscle out, let's ask the question, why is it in the position for it to do what it's doing correctly? It's only putting itself in a position myokinematically. It's putting itself in a position to become a good rotator. Or it's putting itself in a position to become a good flexor. Does that make sense? So the question is, what would you do to reduce the demands on that muscle to restore that muscle's ability to only work on what it's supposed to do. When do you need a TFL? Well, when do you need a TFL? You need a TFL when you need hip flexion and internal rotation. When would that be? When do you need hip flexion and internal rotation of life? Hip flexion and internal rotation of life. You want to write this down? Maybe on that sheet, maybe somewhere else? You need that for pronation. And don't tell me you don't need pronation. We have an anti-pronation mindset in this country. Oh, there's a pronator. God, thank God I'm a pronator, guys. I'm a pronator on both sides. Thank God. Oh, there's another pronator. See him? Those feet are flat. You all need pronation at mid-stance, correct? We all need that. So at mid-stance, when you're at the in range of maximum hip flexion internal rotation, you just seal the deal with that TFL. The minute you get out of that position, should that TFL be firing at that point? No, because your hip has to do what on that side? Re-extend. Therefore, that muscle's gone at that time. But if you can't get into re-extension because you want to stay in flexion, that TFL now is going to act as a rotator. It can't do anything else but act as a rotator. So, and that helps stabilize your femur because you can't use the bicep femoral short head anymore because it's not in the right position to act as an internal rotator. So now your femoral stability is bad. Now you got to use TFL for stability of the femur. And I'm just having fun. Lydia, I'm just telling you all the scenarios. When I look at people and I look at all the scenarios that can occur, I can roll that muscle off because all you got to tell me, Ben, where do you hurt? Where do you feel tight? Where do you feel tense? What do you feel like you can't let go? That's all I need to hear. And once you tell me what you got going on with what you can't let go, I know kind of exactly what I got to do with that family member, or if there are two other members, in this case there's not, so that the opportunity to share the wealth of need that you need from that muscle can be distributed somewhere else. In this one TFL condition, I know that you don't have a lot of internal rotators. Let's count them. Let's go to the top of the page. I see a gluteus medius and minimus. I see a tensor fasciae lata. I see an adductor group called the ischiocondylar adductor, and I see a medial hamstring. I see 4 muscles that internally rotate your femur. Should we count them? I see a gluteus medius and minimus. I see a tensor fasciae lata. I see a medial hamstring. And what's the only other one you got? What was it?
Adductor.
An adductor, ischiocondylar adductor. I see 4 groups, 4 precious muscle groups to keep you internally oriented and keep frontal planism. Keep you shifted over to one side to the other side. 4 groups. And you might want to underline that ischiocondylar adductor group. Because if you lose your ischiocondylar adductor, your TFL will be there in an instant to help you out. In an instant. Now, if you go to the glute max side, Chad, I see like 6 or 7 groups. There's external rotation flowing everywhere. There's a flood over there. We've got more external rotators over there than we know what to do with. Let's count them all. We got an iliacus, a glute max, a piriformis, gemelli, quadratus femoris, sartorius, pectineus, adductor longus, rectus femoris, bicep femoris, and if you want to stick a little adductor magnus in there, you can if you want. Whoa! Do you see all those anti-gravitational muscles? Tons of them. And we're going to break those up by families, which you did below. What's the one family that has, Corey, where's the one family that has your muscle in it? One family has your muscle in it. Find it. Tell me where it is.
Hip extensors.
Hip extensors. So when you say the word hamstring, you got 2 other muscles you got to start to learn today. What are the other 2 muscles that work with it? What are they?
Semitendinosus and semimembranosus.
They got the semitendinosus, semimembranosus. Where'd you read that?
Hip extensors, internal rotators.
Well, let's go to hip extensors. The first one I see under glute max, under bicep femoris long head. Read the 2 muscles that are in that group. You're on the wrong page. Page 15. Go to hip extensors, external rotators.
Oh, adductor magnus and glute max.
Oh, stop. Adductor magnus and glute max are hamstrings. Can Can you believe I said that, Carl? Write it down. Hamstrings. You got 2 more people in your life. Your family's growing pretty fast. Do you follow me? Glutamax. And what was the other one?
Adductor magnus.
Not ischial-condylar adductor. The adductor group, the big magnus muscle as a muscle, and the bicep femoris, and the
Glute max.
are all what?
Hip extensors.
Bingo. They do what?
Hamstrings.
They do what?
Externally rotate.
Thank you. You're only answering the question with hamstrings, but I got you to say external rotation. We're getting a little closer here to understand myokinematics. Therefore, what does a hamstring muscle do? Does it internally or externally rotate you?
Externally rotate.
Very good. Along with what other 2 muscles in the same group?
Adductors and glute max.
Very good. So we know we've got 3 muscles in that family that we're going to use to help extend a hip in 3 planes. Isn't that cool? In 3 planes. We already know the glute max is going to push you over to the other side. We know the adductor is going to pull you in. And what's the hamstrings got? What hamstring qualities? What transverse qualities do all 3 have? Transverse plane. We got transverse plane because they externally rotate. We're going to use that information somewhere in designing a program. Do you see the dialogue I'm having with you, though? If we don't understand that musculature by family and by attachment and by what they do coactively, how can we carry on a conversation on do we want that muscle or not want that muscle? Do I want to take a psoas and an iliacus and put it with my gracilis? No. Do I want to take a popliteus and put it with my adductor brevis? No. Do you guys understand what I'm doing right now? If someone says I've got a pain pattern right here and a pain pattern right here and they don't match up, then I've got some concerns because I got 2 families involved. Because there's 4 things going on here. Knee and hip flexion and extension. Now I'm going to pull you in one more time. What's most important here, folks? To go after the knee flexors and extensors first or the proximal section first? Would it be important to go after the hip first or the knee first? Think hip. Just write down. Think hip. Before you think knee, think hip. How are we doing? Does that make sense, Bobby? Think hip. Christy will tell you, think hip. You got a knee patient? Tell me about her hip. Right, I know she's doing this. Tell me about that hip. And then when you think hip, you got to tell me what you think that hip really needs. What does that hip need? Think hip. Now what's the next thing you should think? Think opposite hip. You guys ready? We're doing it. You got a knee patient? Forget what's going on with the knee patient. You got a knee patient? Think hip. Then you're going to say, think what? Opposite hip. You got a left knee problem? Think left hip. Then you're going to think right hip. You got a left knee problem? Therefore, go for the right glute max. What was the other 2?
Adductor magnus, bicep femoris.
Maybe you want to think about those. Just start thinking that way. Just start thinking families. Chad, do you see what we're doing here for you? Just start thinking. I don't need to get my goniometer yet. I don't need to do any tests. You just told me where you hurt. That's all I want to know. What hurts? What's straining? We do that all the time around here. It goes so much faster. And then all your tests are going to complement. Oh, now I get it. Now I get it. So I'm just trying to help you out with this chart. That's called mental madness. Okay? What do you do with that chart? All right? Now, on page 17 and 18 in your manual, we're going to pull those, we're going to leave them in now, and then when we start coloring, we're going to pull, which is going to be in a few minutes, we're going to pull them out and lay them by your side. But I want to tell you about these 2 charts, okay? On page 17, you have positional and compensatory influences of the left AIC pattern on muscle of the lumbopelvic femoral region. Positional and compensatory influences. St. Louis Shirley Sarman thinking people. You're going to love this, okay? So if you go to that page 17 and you look where it says left side, you see where it says this is the left side? And then go over to page 18 and you see where it says the right side. You got page 18 and 19 devoted to the right side, and you got pages 17 and 18 devoted to the left side. And we'll start on page 17. And it says, patients with a left AIC pattern who are positioned in a state of right AFIR and left AFER present with the following relationships. Katie, I'm going to demonstrate that. Patients in a left AIC pattern would be patients who are in AF what? IR, stand on the right side, Drew. I'm over here on the right side, and I'm in AFER on the left side. That's that state. Underneath of that, it says left side. Let's start with the left side. Let's review. The left innominate is positioned in a state of AF flexion. You've not heard that today until now. Underline AF flexion. Abduction and external rotation. And then underneath of that, the femur has to compensate if you can't get out of it. And what we did is we then gave you how those femur muscles are compensating if you cannot get out of it. Okay, we're going to come into that. The efforts to restore and correct AF position and rehabilitation of FA activity on that left side should include extension, adduction, and internal rotation. Let's underline those three things. Extension I need on the left side, adduction I need on the left side, and can you write the word pronation on the left side? Or, if you will, internal rotation on the left side. Now I'm going to skip over this, and I'm going to come back to this. Now we're going to go to the right side. Okay, we'll come back to it. Just put a little hold, go to page 18. On the right side, the right innominate is positioned in a state of AF extension, adduction, and internal rotation with positional femoral activity. You're positioned there. You're not compensating, you're positioned there. Did you see the two words difference? So over here you should have wrote the word compensatory. You see that? Over here you're going to circle the word positioned over there. You have a brain that wants to position you over to the right side, and yet that same brain is trying to help you compensate on the left side. That opens a whole bag of worms for the PRI. That gives us 6 or 7 other courses, Jen. Whole other world out there. Compensation versus what? Position. If you can't shift. So on that side, the efforts to restore and correct AF position and rehabilitation, AF and FA activities on the right side should include the following. We need more innominate flexion on the right side, abduction on the right side, and external rotation on the right side. Correct? That's how we would look at this myokinematically. Now what we did is we went back, and for each one of those muscle groups, which I won't do today, you'll have to look at this on your own. If you go back to page 17, let's go to the flexors, the iliacus. And it says, well, that would be the flexor iliacus and psoas. Here we go. They are going to be short and strong. Underline that, short and strong. And then we give you the reasons why. The rectus femoris is going to be short and strong. Underline short and strong. And we give you the reasons why. The TFL on the right side. Excuse me, I'm so sorry, folks. The TFL, I'm on the left side. On the left side will be short and strong. Let's go find the TFL on the right side for kicks. Should we go find it on page 18? The TFL on the right side will be short or more than a normal length. So what you could do with these two graphs, Chad, is you go from the left side to the right side and start asking yourself, what are these two muscle groups really doing? How are you using them in that position? We're going to color some muscle this afternoon. And we're going to lay this sheet, 17 and 18, in front of your coloring book. And I'll say, everybody go to the right side and tell me what that glute max is doing when it's in this position on the right side. What is it doing when it's in this position on the left side? Do you see how this works on page 17 and 18? If you really want to know what your patient's doing after you examine them, you'd find out the position they're in with their adductors, with their pelvis, whether or not they can adduct, extend, and rotate. You would possibly go to this. By then, you'll have an appreciation for attachment sites. And you can start to get a picture, Pat, of what's really going on with respect to AF activity as it relates to muscles that either are short and strong, short and normal, weak, whatever. Let's go to the next group because they can't change. The next group says that the extensors are going to be long and weak, long and weak. The glute max fibers will say the extension fibers are long and the weak and out of position for optimal extension. And what I would encourage you to do is take your pelvis or take a sheet that has a pelvis position on it in this manual, pull it out, put it in front of you, and go through this. I get that. I could see why that would happen. I could see why this muscle, after I reposition him, Gibby, is going to need some strengthening because it's been in a long, weak state for a very long time. Now, we based our PRI program algorithms off that mentality. Before you would choose this muscle, you probably ought to get this muscle stronger before you move on to a different plane for the reasons outlined in page 17 and 18. If you go to the abductors on the left side, these abductors are in a position that become very short over time. Secondary to abduction, external rotation, that's compensatory. Look at how many words of compensatory are listed there. Compensatory, let's start from the top. Almost always, see the brackets around the word compensatory? Compensatory, compensatory, compensatory. There's a bicep femoris is positional, but see all those compensatory words? I will tell you right off the bat, on the left side, Chad, you have a compensatory world. It's a compensatory world. You change that orientation, and now you got to make it non-compensatory. To make it non-compensatory, you're going to need some strength in muscles that need to be normalized in position. Your programs, should you elect to do this, are going to require more operational definition for activity that needs to get better, stronger, in a more normal state on the compensatory side, regardless of any course you take in PRI. You're going to need to inhibit more and reduce positional issues on the non-compensatory side. Which side would that be? And the entire body, Bobby. Thank you. On the right side. So we're in this building thinking in the building across the street, if we see the word right somewhere, we're thinking that right side, we're trying to reduce positional issues. We're trying to inhibit things on that right side. Positionally. It's not a compensatory problem over there like it is on the left side. That's how that works. So I think it's a really nice little gift. That wasn't there a few years ago. There was other speakers helping us out with this institute, and I love it. And then if you go to page 20, we have this little process where we actually start looking at where these muscles are. Let's start with this group right here before we get the colors out of the coloring box, okay? What do you see, Carl?
Hamstrings.
Nice job, okay? Whoa. We're ready to get the colors out. What's the first thing we see up there? We see these hamstrings. And what do those hamstrings look like they're doing? Do they look like they're laying right next to the femur, or are they laying posterior to the femur? Guys, write this down. Hamstrings need to stay behind the femur. If you lose 30 degrees of lordosis, hamstrings approximate femurs. Your line of pull now is lost. Your leverage is lost. Make sense to everybody? First slide up there says, Carl, hamstrings need to be behind the femur. It doesn't say that, but it kind of says that, doesn't it? They have to be behind it. You see pictures of the bicep femoris, short head, long head, and the semitendine sendai membrane. And they all kind of got to be behind that femur. Bobby, what happens if I take this ischial seat and roll it up in the back and drop this anterior superior iliac spine forward which way would that femoral head go? Back or forward? It would go back, and this would come forward, which means this line of pole will go from here to there. If this is going forward and that is going back, your femur technically could be behind your hamstrings. Could you write that down? Anterior pelvic tilts place femurs behind hamstrings. Hamstrings, Bohannon will tell you, now become quadriceps. Weird day today in Lincoln, Nebraska. They're converting quadriceps to hamstrings in Lincoln, Nebraska today. That's called knee hyperextension. That's called patellas that swim around on femurs they can't touch anymore. That's called ACL-itis, Bobby. That's called poor tracking. Poor sensory identity for where should I put my femur and my patella. And I'm making kind of a big deal out of this because I'm not sure it's been made a big deal out yet. Femurs that stay ahead of hamstrings allow quads to work correctly and diminishes the need for more hip flexion activity. Can you say, I see this slide saying, learn how to squat. I didn't say lift weight. Learn how to what? Squat. Learn how to take a two-joint muscle and bring the knee which way? Forward, and the pelvis which way? Back. That's what I see in this slide. If you're a physics, and I've got lots of brothers and sisters who are engineers, my son will tell you that. If you're an engineer, you'd say, hey, I don't see a hamstring. I see a rope that's pulling a pelvis in a position that complements a knee that's got to go which way? Forward. By the way, you don't need ever to overextend your knee to walk. Ever. Never do you need a knee to overextend. On the contrary, always should you be thinking about how to keep a knee from locking what? Out. On the contrary. And I guarantee you, Chad, there's a guy to your right that knows what muscle is going to do that. So when I look at this picture, I keep thinking to myself, what is it that we got to do to get people to understand that all myokinematic activity in the lower extremity, in the lower chain, and the pelvis requires this simple thought. Is that femoral opening staying behind that foramen obturator? Because if the foramen obturator goes behind the femoral acetabular opening, you will never stop using your quadriceps to pull your pelvis forward and diminish two planes of activity, frontal and transverse. Sheila, that's a major important issue when you work with people that you're working with and you see them get through with your program and lock out. There's no in between. Or walk around and lock one knee out and lock one knee out. Or not be able to shift with a little bounce and a little what? Decompression. Quads decompress the joints. Quads decompress the joints. Do you follow me? They decompress the joints. They don't compress your joints, they decompress your joints. You can cut a quadricep muscle and still walk. You've heard me say this, Gibby, many times. I used to work with amputees all the time. We never depended on quadricep muscles to walk. But you cannot cut a quadricep tendon called an ischial tendon, a semi-tendy, semi-mammy bicep femoral tendon. Take a core knife and cut it here. You will not walk without a hamstring. Do you understand that? Without having crutches in your hand, because nothing's holding you up. You will fall. So we know when to get the Canadian crutches out with people who don't have what? Carl, what?
Hamstrings.
And we know when to put them away when people don't have what? Quads. Quads that are weak tells me that you don't need crutches. Quads that are weak mean you need to give them what? Hamstrings. And reline and relocate holes. You know what those two holes are? The acetabulum and the obturator foramen. Otherwise, you got things out of place. And your whole system's going to know it. There's no way you're going to escape it, Pat. So I really like this slide. Are there any questions about this slide? Yeah.
When you're anteriorly tilted, basically you're only getting the extension in a weakened state with the hip extensors. Your adductor magnus is kicking in to help a little bit. Your glute max is helping to kick in a little bit.
And by the way, what are those muscles called? External rotators. Those are external rotators. So now you're starting to do, I love it. Thank you for the question, Drew. Look, you're doing that and you're compensating. External rotation.
You're extending with your back too. Is that
Back is extending? Absolutely. Thank you, Drew. And that happening on both sides is worse than if it was just happening on one side. Because if it's only happening on one side, do you follow me? You can get them to start getting out of it by shifting with an internal rotator and a frontal plane muscle. If it's happening on both sides, you got to pick muscles that are not only going to put them into a neutral state, but muscles that loosen them up. What muscles loosens them up? What muscles loosen? Hamstrings. They're now holding themselves up with their hamstrings and they can go from side to side because they're being held up. And they can start to move from side to side with their, you were right, their adductors. But before you can give them adductors, they've got to have support. What muscle flexes the knee and extends the hip? Hamstrings. What muscle decompresses the knee and decompresses the hip? Hamstrings. What muscles get you in the position so that you can sense shift? Hamstrings. But if you can't get any of that and you go after the adductors first, maybe we can do that. It's a great question, Drew. It really was. It's an excellent question. That makes sense, everybody? Man, it should be that far, but you guys got the picture, right? Drew, that's a great question. Did I answer your question? Did that answer it? It was a great question. I want you to take out some colors, okay? I just like this picture so much that I can't leave it. I love this. In fact, we got 3 of them. Look at that beautiful picture. Do you see that beautiful picture? Because, Drew, this is your picture. When the ischial seat comes back on the posterior side, that's called adduction. Do you see the line of pull? When this comes back, that's called adduction. When this goes forward, that's called abduction. Man. Somehow over the 20 years that got lost, I think. When those hamstrings kick in, you're going to adduct because one of our best hamstrings is the ischiocondylar adductor. It's innervated by the same nerve. It's coming off the same side embryologically. It's on the same bud. It should be a hamstring. I just read an article the other day. Where is it?
There's 2 actually 2016 articles, and they're in the first page of your references in the appendix. One of them by Brodsky and Murphy and several other authors, but the title is The Adductor Magnus, in quotes, Mini Hamstring, MRI Appearance and Potential Pitfalls. The second article is by Obey, another Brodsky article. Obey, Brodsky, and some other authors studying the anatomy of the adductor magnus origin, implications for proximal hamstring injuries. So this person with the last name Brodsky is climbing right up our same ladder.
We're on the same tree, climb up the same ladder, thinking the same way. Because, Katie, if you go back and look at it, I would never have called the ischiocondylar adductor an adductor. That person wouldn't have either. It would have been called a what, Carl?
Hamstring.
A 5th hamstring. Okay? And Drew, now you can see why. Because as that hamstring, that adductor's contracting, you're getting the same activity in a hamstring at the expense, good expense, of adduction. And so we put heavy emphasis on co-activation of adductors with Carl's hamstring. That's a cool concept. I'm going to go a little further. This adductor group with this hamstring group complements the abdominal wall on the opposite side. So this abdominal wall and this adductor, when extending, helps me with my rotation and flexion on the contralateral side. It holds me up. This adductor, this hamstring, should complement this abdominal wall. But if this side, let's check page 17, becomes compensatory and it pops up in the air because you're going to fall, you already know you're no longer a good human being. Because now you have nothing over here pulling you back over to the what? Left side. Your abs are dropped off. They're no longer in a family that should be complementing what you just discussed. This abdominal wall and this adductor, this abdominal wall is on, but this adductor is off. Now we got a problem over here. This isn't compensation. This is positional abdominals. Positional abdominals, compensatory abdominals. We got a problem. For me to get these abdominals to work with this position issue, I've got to make sure that Drew's adductors and hamstrings are pushing me, moving me over which side? The left side. Did that make sense to everybody? That's a nice complementary pattern. That's why I can pick my leg up. I can pick my leg up, move to the left, and work my abs with the right trunk rotation. If I can't do that, I don't have those complementary activities going on. And that's why I like this picture. This bicep femoris muscle, has a short head and a long head. This is the short head, this is the long head. This short head is an internal rotator. You always know that because the long head is a external rotator. So this short head's an internal rotator. Right here off this short head, there's another muscle coming off right here that goes all the way up into this pec area, this pectineal area called the adductor magnus. So under that page where it said, what's your number one femoral stabilizers of your femur? You would say bicep femoris short head because it's lined up on the linea aspera along with the adductor magnus, and those two muscles give you the ability to rotate your femur. Give you the ability to rotate your femur because you got to rotate your femur without locking the femur up as it's stabilized. There it is. There's the bicep femoris short head. And what's this muscle right here called, everybody? The adductor magnus. This is stability. Someone asked you a question, Pat, after today. What's the best stabilizers you have of your body when on one leg? Of your body when on one leg you would roll out, well, of course, it's the bicep femoris short head and the adductor magnus. Of your body, of your entire body, when on one leg. And I'm going to tell you a secret. Quadriceps and the research are considered destabilizers. Isn't that cool to know? They're destabilizers. You got a little tendon going to a tibia for destability. You don't need transverse stability from a quad. They are meant to be destabilizers when you extend the knee. Are you ready for this? Reverse the muscle. Hamstrings are knee stabilizers. You got a medial and lateral side of those hamstrings with a central tendon called the tibia. Ooh, wrong course. Ischial-seat. They're just reversed. The hamstring tendon on the ischium acts as a destabilizer for looseness and a stabilizer for the knee, along with the destabilizer of the knee being the quadricep and a stabilizer of the pelvis. So every time somebody says I'm going to do a quadricep program, I go, okay, that's great, that's cool. But Pat, are you going to do that quadricep program without a bicep femoris short head and an adductor magnus? Because if you are, all you're doing is teaching that individual how to go into 30 degrees of more lordosis, to help them stabilize a femur so you can satisfy your mind that you got their quadriceps stronger. In a position, Lydia, that isn't going to help them at all because now you overextended their knee. You moved the obturator foramen which way? Back. You're now in the wrong position for leverage, and I hope I'm not losing you at this point. You have no push-off at this point. You're already in it. You're in push-off. You have nothing left. You've already pushed off. You're forward. Everything's already messed up. To get that back, you got to go back and get that obturator foramen and that acetabulum to be what? Repositioned. So do you see all the reasons now that we're talking about? Let's add them up. We need it for spinal regulation this morning. Remember the orientation? We need hamstrings for spinal regulation. We need neutrality for spinal regulation. We need it for frontal plane shift. We need it for stabilization when the knee is what? Flexed. Stabilization when the hip is what? Extended. And we need it for breathing. We now are at a point with this course that we want to go to our manual and color muscles that pertain to myokinematics of this lumbopelvic femoral region. And I really wanted to do this with Jen. Jen Platt is our Director of Education and Credentialing here at the Institute, and she really loves this course, and she's putting this course together with us in a really objective, formatted way. So she thought this would be good. I think it's a good idea, so I want to include her in the discussion. She's going to help us out with looking at positional and compensatory issues with each one of these muscles, and her background in looking at this course from a multiple faculty perspective is so sound that I really wanted to include her. So Jen, thanks a lot for doing this, and we're going to put her on the other side of the table so I have somebody to talk to, and we'll get started. In the manual right now, we are at page 20, and you have your coloring boxes in front of you, hopefully. And we're going to use about, I think, 6 or 7 colors here. We'll go through each one of these muscles by color. These colors are part of a family of muscle that the Institute covers every year at the Advanced Integration course. And at the time, it may not seem significant, but we really think there's a benefit of coloring these muscles for a couple reasons. One is it gives you some more of an awareness of where they attach and where they're going and where they're coming from. Number 2, it helps us understand how they lay out next to each other and how they're actually working possibly with different colors of muscles. Each muscle color has a representation of a group that will either rotate attachment site, flex or extend attachment site, or adduct or abduct attachment site. So I think as long as you keep that in mind, if there's a bigger picture here, I think it'll be helpful from that perspective as well. And finally, I think the coloring gives us an opportunity to reflect on the biomechanical dimension of what this muscle is really all about. Sometimes you look at a muscle and it can become it's misleading. It looks big, but really when you look at where it attaches to the bone, there's not so much area there. Or sometimes a small muscle looks small, but if you look at how it attaches to the bone, it carries a lot of weight, or it carries a lot of meaning because of its attachment size versus the muscle size. So there's lots of good things about coloring, and we'll go through more of those with Jen's input and our discussion. So Jen, with that being said, I think what we're going to do is we're going to have Jen go over if you take page 16, 17, and 18, and 19 out of your manual, just click open your manuals, take those two pages out, front and back, have them at your side, or have them there to easily get to. And Jen's going to start on page 16, and we'll talk about a muscle. She'll tell us where they attach, and then we'll go and color the muscle. And then I'd like to carry out some clinical dialogue with Jen regarding what that muscle really is doing in terms of is it compensating? Is it positionally oriented in a state that it can't do things that we want it to do? And I think you'll find that enlightening as well. The other thing I think we should remind you is that we're going to be talking about a left and right side. the person that we're talking about is a human who has a left AIC underlying pattern to him or her. And that left AIC pattern puts us over on the right side, and therefore we're going to color some muscles on the right side, we're going to color some muscles on the left side, because we want to look at this biased state that these muscles usually are in because of position that we put them in, neurofunctional position we put them in. So if we can look at this muscle from a perspective that, hey, if we go to this side, we're trying to offset this left anterior chain of drive so that we can move from side to side, as you all at this point know, hopefully. So Jen, on page 16, let's start off with the first color. It's going to be an orange color. You'll pull out your orange color, and Jen and I have already taken the orange color. We put little dots by the word gluteus maximus. Gluteus maximus is going to be colored orange. And then when we even talk about the what's on the back of page 16, 17, 18, and 19, you might want to put orange by that muscle when we get to that point. So we'll keep the orange in your hand, we'll listen to Jen, and then we'll go to page 20 and start coloring it, okay? Jen, what are the attachment sites for this muscle?
So on page 16, it's going to be the fourth muscle listed in that top box of external rotators. And I just put a little R right next to gluteus maximus because that's the side we're going to be coloring. And then if you want to use your orange crayon, highlight that word. The proximal attachment is going to be the posterior ilium to the posterior gluteal line, the dorsal surface of the sacrum and the coccyx, and the sacrotuberous ligament. Distally, this muscle is attaching to the IT tract that inserts to the lateral condyle of the tibia, as well as the gluteal tuberosity of the femur. And something that in our institute you won't see us use are the words origin and insertions, and Ron talks about this a lot. As soon as you say the word insertion or you say the word origin, you could flip the terminology around, and it could really change depending on how you have the patient positioned, whether it's open chain, closed chain, what activity is really being done with that muscle. So rather, you'll see in this chart the words attachments, because there are multiple attachment sites, and depending on whether you call it an insertion or an origin, can really vary. And if Ron wants to chime in on that any further there, he can.
Job. And I think it's important for us to say it right now. We really have no problem, Jen, with people calling it an origin or insertion. I mean, we were taught that in our
Yes.
program. And for the most part, chiropractors and athletic trainers and people out there that study muscle are going to look at O and I's because that's what's in the manual. It's by the way, what's in the textbook. And obviously in textbooks, as you all know, you open the book up to knee or hip or shoulder, there's no distinguishing differences in the textbooks, whether they're orthopedic, biomechanical textbooks or neurological ones per se, where there's an actual described difference. Research has not actually said this is a different joint because of, and we're trying to do that now. We're trying to make sure you understand that this joint may be in a position or a state where it's hyperactive or hypoactive because of what we need from it to stay upright. And so myokinematically, we got to look at the muscle kinematic and kinetic activity or influences on our body. And therefore, if you call it an O, and Jen, you're so right, and that O is really acting as an I, or your I is really acting as an O, it's really not reflecting in our minds correctly what's going on with our compensatory issues that arise because of the possibility of that O being an I and that I being an O at the time that you look at that muscle. So we're trying to be safe about this and make sure that people understand that O and I's are fine, but attachments today I think will make more sense once we get through this discussion. So if you go to page 20 and you take your orange color out, and Jen's already given us those areas where it attaches, and you color the 3 on page 20 orange. That's the lower part of the sacrum's attachment of the gluteus maximus, please note. It's the dorsal surface of the sacrum, and we're coloring the right side of the sacrum. And as I'm about to show you clinically, the need for us to color that side will make more sense once we complete the coloring itself. So you got this number 3 colored orange on page 20. On page 21, colored number 3, again orange, and that would be the lateral surface of your hip bone, again on the right side. It's a good perspective view of how little attachment actually occurs on this ilium or this innominate. This is a triosseous muscle. Jen named 3 bones that it attaches to. It's one of the 3 muscles in myokinematics that the myokinetic course that is actually being discussed as a triosseous muscle. The piriformis is the other one, the iliacus is one, and this wonderful muscle called the glute max is one. Now, Jen, what were the 3 areas? It covers the ilium.
Ilium, the sacrum and coccyx, combine those 2. The femur, and it actually attaches to that IT tract of the tibia too. So there's actually 4 attachments.
4, yeah.
Primarily though, those first 3
are what we look at. So it's a muscle that pulls us together. It's a muscle that shows us we're in range of activity, especially when we move our femur internally on our acetabulum or acetabulum internally on our femur, and I'm going to describe that to you in a minute. So it didn't take very long to color that. We're going to go to page, I believe, we're going to skip a few pages, go over to page 26, and there's that line, if you will, along the femur where the gluteus maximus attaches parallel with the femur. You have this line on this lateral side of the right femur, and then if you go on to the medial side of that same femur, you're going to see a line called the linea aspera, which another group of muscles go to, which we'll color as well. But those 2 lines tells us that this thing needs to move. This thing is the femur. And so this is a rotator. This orange color is a rotator, and it's being used as a muscle that pulls 2 joints together, primarily the sacroiliac joint, because it crosses over that joint, and the acetabular femoral or the femoral acetabular joint. I don't believe there's anything more you need to color. I wouldn't mind now going to page, I believe, is it 17 or 18? 18, on the bottom, page 18, Jen?
Yep, so the very bottom of page 18, and just an overview, again, this pages 17, 18, and 19 is looking at the positional and compensatory influences of the left AIC pattern on muscle of this lumbopelvic femoral complex. So the first side of this 3-page document is going to go over the left side. And it gives you a good overview before it even gets into these muscles. The left innominate is positioned in a state of AF flexion, abduction, and external rotation with compensatory femoral or FA activity. And so all efforts to restore correct AF position and rehabilitate FA activity on the left side would include extension, adduction, and internal rotation. So now it's going to break down these muscles into this group on the left side, and it's going to do the same thing on the right side. So since we just colored the right gluteus maximus orange, I'm going to read here on the bottom of page 18, the glute max, it's in the extensor group, but you'll also see in parentheses behind it, it says ER for external rotation. The external rotator fibers are long, weak, and out of position for optimal external rotation, secondary to internal rotation, which is positional in this left AIC pattern on the right side. The extension fibers are short, strong, with optimal leverage secondary to extension. Again, that's positional.
So if you look at a diagram of this muscle, which we have here from Travell and Simon's book, volume 2, you can see that if you look at it, you can see now that it's coming off the sacrum, coming off the innominate, the ilium, and also coming off the femur. And the lower fibers are primarily used for extension. When you put your heel on the ground, Your glute max is primarily there to allow you to keep that sacrum close to the femur as you push yourself forward. The upper fibers are more, or the middle to upper fibers are more rotator oriented. So when you put your foot on the ground and you start to pick up your left foot and you start the swing phase of gait on the left side, the ipsilateral side or the right side needs to have sufficient extension so that sufficient ER activity can come from that same muscle. Now, if you remember when you colored it, you colored the middle to lower aspects of that sacrum. And if that lower sacrum is in a anteriorly rotated position and it's tilted forward and to the right, as you'll see here, if this pelvis is anteriorly rotated and now forwardly rotated more so on the left than the right, this oblique axis of this tailbone, the posterior edge, will come up towards the ceiling as the anterior posterior axis. If you put a axis right through the middle of this, it will start to also rotate this way a little bit, and then it's going to go through a vertical axis of rotation, all resulting in this sacral coccyx leaving this femur or leaving this innominate, and that's where it becomes very long. So its power is lost as an external rotator, but its power is gained as an extensor because it's got a better position to pull. So that positional issue can then put it in both a positional and a compensatory state. And Jen, I want to ask you to read this again. You said the extension, when we look at it again, the extension fibers are short and strong with optimal leverage secondary to extended position. So this is more of an extended hip, and this is more of a flexed hip. And that extension on this side makes it difficult for this to become a rotator. So we use the glute max and PRI to help reposition along with the left hamstring and along with the left adductor. But this muscle is a great muscle to actually move us over to the left side to handle mid-stance of the gait cycle on that left side. In order for us to pronate correctly on the left side, this right transverse muscle, this right rotator, is needed to get us into a state of ER from the A on the F through the F. So in other words, that foot's on the floor, A is going to move on that F to get that contralateral FAIR during mid-stance. And then that leads into AFIR on the left side after you're in that early mid-stance phase of gait. It's a big muscle, and it's not that big in terms of attachment site, but it's really big when it complements the need for us to really pull everything together across the acetabular femoral joint and the sacroiliac joint. Jen, is there anything else about that muscle that we probably need to talk about clinically?
You know, it's a big triosseous muscle, which Ron, talked about already. It's one of the few muscles that crosses that SI joint or that iliosacral joint, as we like to refer to in this course. And so it can really influence closing a gap. Usually on that right side, you're going to have an iliosacral or an SI joint that's usually gapped, and that glute max will help to approximate or pull that joint together.
Even on the left side, the anterior left SI joint could be unapproximated or decompressed, and if we want to get it more unity or more uniform activity on the left side, we would consider using the right glute max. Now, the right glute max, there are lots of techniques in this manual that are suggested in terms of what you might want to select. Those techniques are by different positions, whether it's supine, standing, sideline, et cetera, But for the most part, keep in mind that this is, number one, it's a triosseous muscle. Number two, it's an extremely important muscle to shift our center of masses with. And number three, that it has a compensatory and a positional aura about it. And if we can't get out of that aura, which means there's something that's probably feed forward going to happen if we don't use this muscle in its correct position at the correct time. things will fall apart. And the first thing that's going to fall apart is your center of mass will want to stay over to the right side. Humans like to keep their center of mass over to the right side. The next color we're going to color the next muscle we're going to color is this thing called the piriformis. And the piriformis is going to be colored with a yellow color. I'm on page 20 again. And what we'll do before we color it, we're going to listen to Jen's description of the piriformis's attachment sites. And again, that would be on page 16.
And again, we're going to color on the right side. So if you want to put an R or right next to this piriformis on page 16, it's right beneath the gluteus maximus muscle. Again, it's in that external rotator column. The proximal attachment is going to be the anterior surface, or that pelvic surface of the sacrum, and the sacrotuberous ligament, as well as the superior border of the greater trochanter of the femur. Now, one thing that a lot of places don't mention this attachment site, but it also attaches to the ilium that we're going to color here in a couple pages. So you might want to just write that in on this page, but it's not often recognized as an attachment site. But this is another one of those triosseous muscles where you'll see where we're going to color 3 different bones coming up here in the next couple pages.
Right. So again,
And
we
then
remind
the
the reader.
distal attachment
Right.
is that superior border of the greater trochanter of the femur.
Right. So well said. And again, this is a very important muscle when you start looking at SI dysfunction or function, when you start looking at things that walk in your clinic that are labeled with piriformis syndrome, whether it be the left side or the right side. After we color this, I think you'll understand that we always go after this methodically. We look at the piriformis as a positional versus a compensatory muscle. It would make sense to take it out of a wrong position so compensation can be reduced. This is one of those muscles, if you do not consider positional issues, compensatory issues are going to be a problem. And piriformis has compensation written all over it. So let's color it on page 20. If you take out your yellow color and color number 1, yellow. Color number 1, yellow. And that is the pelvic surface of the sacrum. You're looking at the right side, not the left. So both of these muscles so far that we talked about are on the right side. And if you go to page 21, you color number 4, yellow again. It's not a very big amount of real estate on that lateral surface of that right hip, but it's enough to give it integrity and a sense of well-being. So that piriformis is often forgotten about in terms of its influences and attachment to the innominate directly, not indirectly. And then if you go over to page 25 and you color the greater trochanter's attachment of the piriformis. And again, it's important to understand, I didn't say piriformis attachment to the greater trochanter. I said greater trochanter's attachment to that muscle. Our bones want attachments. We need it. So we want to keep that bone in the right position for that piriformis to function versus put the piriformis in the right position. And this particular muscle needs bony assistance from the muscle we just got through coloring, for example, or the hamstring on the other side to stay in the right position. So please color number 1 yellow on both of those diagrams. You have one from the medial side and you have one view from the front on the right side as well. On page 26, if you also look at the bottom, please color number 6 on both of the diagrams that are on the bottom. One says from the lateral side and the other one says from above. And the piriformis, if you look at it, Jan, the one above, if you look at the mechanics of that attachment, that it's not a biased muscle. It's attached directly to the middle of that trochanter. So it's not really a bias muscle for rotation of a femur. It's more of a bias muscle because of where it attaches to the sacrum and the innominate. So the femur is really a post hole for it, but it's also a good place to start our thinking process on what that thing should do once your foot is on the ground in a closed chain. really don't have anything else for you to color. We're going to go back to the discussion, Jen, on page
19. It's going to be in the last section on page 19, listed as an additional rotator. Again, this is the right side, so if you want to write the word right in front of piriformis, in parentheses you'll see afterwards it has ER for external rotation. And this muscle on the right side is long and weak, secondary to internal rotation, which is positional. And this is a muscle that I will also want to now go out and I'm going to read for you the left side.
Which is a good idea.
Because we're going to have a little discussion here on right versus left side piriformis syndrome or any other influences such as SI joint instability or pain, which is very similar and can be caused by this piriformis muscle. And we're going to kind of have a clinical discussion on these two muscles. So on the left side, again, it's an external rotator, but on the left side it is short and strong, secondary to external rotation, which is compensatory. So on the left side we have a compensatory problem, on the right side we have a positional problem. On the left side we have a short and strong muscle, on the right side we have a long and weak muscle.
So Jen just said on the right side we have a muscle that is going to be more long and weak. Long and weak. On the left side, it's going to be a muscle where it's going to be more short and strong. So it's trying hard to get this femur to turn the foot.
See that.
It's trying
I have
hard
to hold it like in front of you because it's kind of being blocked
Okay.
by your body.
So this is looking at it from the front, but if you look at it from the front, the piriformis action on this left femur would be to straighten your foot out. All of these patients that we're talking about have an inclination to actually walk in a clockwise position. Without the triosseus muscles doing their job, alternating activity will be difficult. And so they start to take on a biased approach to counterclockwise, that clockwise direction of orientation. And this is a good example of that. The piriformis on the left side will become short and strong in attempting to keep you going straight ahead. The one on the right side is saying, wait a minute, I like going to the right side. It's my mode of operation. It's my MO. And when it starts going to the right side, that left side's got to get stronger. It's got to get shorter to offset that. So it's not a muscle that's used only to compensate to externally rotate a femur. It's a muscle we're using to try to keep us from going from over rotating to the right side. It never successfully by itself can get you over into left AFIR. It'll just help you, assist you from falling too far over to the right side and losing your balance. So very difficult group of people to treat. If they come in with left SI pain or left piriformis syndrome, the first thing that Jen and I would probably encourage you to do would be to take care of the positional issues on the contralateral side, which would be your right side. Make sure that triosseus group, that would be your glutamax and your piriformis, are in the right position before you start treating this compensatory tone that's high on the left or weakness that's on the right. Are they capable of moving over to the left side? And if those triosseus muscles are not in the position or are not working in the direction of alternating activity, it's going to be a problem. I find left SI and left piriformis patients really, they're painful to work with because we're trying to reduce a pain pattern on them that they don't want to let go. They need that pain pattern, that reminder on how to compensate. So you can take their pain away, but if you don't encourage them to go after a program that's going to keep those triosseus muscles complementing each other, it probably is going to be difficult for the patient to accept, and it's probably going to be difficult for you to move them forward with the program. So we hit these two muscles pretty hard in myokinematics. I think we probably killed the coloring on that one. We have one more triosseus muscle. We call this it's a disorganizing muscle. It can be diabolic. It can be dysfunctional. And it can play many roles. In fact, we talk about this muscle in the pelvis course extensively with regards to inlet and outlet and pelvic floor orientation and position. In this course, we're going to color it black. In this course, we're going to talk about its role and how it can be influenced again by lack of having that complementary support from its counterparts on the other side, or its colleagues on the ipsilateral side. So why don't you take your black color? By the way, this Snetter slide that you have that we did not talk much about is a good slide that shows you the degree of external rotation fiber in this myokinematic region called the pelvis and the hip. We have a lot of external rotation fiber, and that piriformis, if you look at it very closely, it's right under the mid-belly of that glute max. And one of the reasons why it's so hard to get that piriformis to work correctly is because sometimes the glute max is not assisting that piriformis in the way it should. So we actually would probably want to start off with a program using the right glute max, and that way we can then get to that piriformis more easily. We don't have a piriformis program per se. We have a glute max program per se, and that's the reason why. It lays directly under that group. It's a triosseous muscle, and it's on the right side. Now, go ahead and take your, by the way, this is for review. If you look at page 21 and you look at, again, this PowerPoint, small little surface on the innominate you just colored. You colored a small little surface on the top of the greater trochanter. And those small surfaces are all big when you start losing glute max power or support. You often rely on those small surfaces for the same activity that should be carried out by a bigger gluteus. And here is your iliacus. It's on the inside of your innominate. It uses the innominate as a sesamoid bone. In other words, on one side of the innominate you have your iliacus. On the other side you have some muscles that we're going to color a few minutes from now. They're called the gluteus medius and minimus. And I think, Jen, I'm going to talk about it right now, looking at this slide. There is really no such thing as an iliopsoas muscle. There are two muscles. There's an iliacus and there's a psoas muscle. Same innervation. They attach to the femur in the very same location, but they definitely do not attach to the same bone above that femoral attachment. One is completely related to the spine and one is completely related to the innominate, the hip. They by no means do the same thing, therefore. And so I see a lot of textbooks, and I still see literature to this day that refer to the iliopsoas muscle. I've been teaching this course for now close to 30 years, maybe 30 years. And I remind people that when you say the word iliopsoas, it makes me feel like what's important here is the femoral component of that, and what you're forgetting about is the essence of this course. That is, the psoas is a muscle that regulates spinal movement, and the iliacus is a muscle that regulates innominate movement. Two different things, and they are supposed to work that way. They are supposed to work independent of each other. They're supposed to respect each other, but they're supposed to work independent of each other. One is going to be more responsible for rotation of your body. That would be the iliacus. The other one's going to be responsible for more rotation and lateral and forward movement, and that would be the spinal component. The iliacus is a muscle that does help you with abduction and adduction, but it's really there to be put in a position so you've got a powerful rotator, both of the hip itself, the innominate on the femur, and the femur on the innominate. The spine is flexible. When you turn your femur with that muscle that goes up to the spine will move. Now, if you have to really help overcome forces, the spine will get straight, it will get tight, and now the psoas becomes more like your iliacus. And when that happens, all bets off on any program. You go into extension pattern, you usually stay on the side where that's occurring, and in this case, it's the right side. That's a clinical discussion. It's a good time to talk about it. And Jenna, do you want to add anything more about that? So let's take your black color on page 20, and let's color that